And now to patellofemoral cartilage repair. So we've heard mentioned a few times they need, first-time dislocators need surgery when they have a cartilage injury. Usually we mean when they have a loose body. That historically has always been the indication for a surgery. But when it comes to just cartilage defects alone, so this is a patient who had a patella dislocation, you get an MRI scan, they do have cartilage damage, they don't have a loose body that would force your hand. So who and when do we operate on these patients? Because cartilage defects are incredibly common, especially in the patella. There are multiple studies that have looked at the incidence of cartilage defects, and besides the medial femoral condyle, the patella is the second most common location. So not every structural defect causes pain. I'm sure you have done medial meniscectomies on patients who had only medial, no anterior pain, and yet there was a patella cartilage defect, which we can ignore. So not every defect that you see causes pain. And pain is not always structural. We see a lot of patients with anterior knee pain, they're deconditioned, but the MRI scan looks perfect. Clearly, we don't do anything surgical for those. So not every defect needs to be treated. So which defects can be ignored? This is now specific to patellofemoral defects. So if I see a patient who has a small defect, they have instability, but they don't have pain, I don't get too excited about repairing this cartilage defect. If I see the typical inframedial patella facet defect from a dislocation, so the most medial, the most inferior part of the patella, those patients frequently don't have any issues because this part of the patella does not get loaded very much in normal motion. It gets damaged when they dislocate, but not during normal motion. And then if I see an older patient, maybe they are a chronic maltracker, and they have an infralateral defect, and we've decided that they need a tibial tubercle osteotomy anyways to unload them or for their instability. TTO unloads infralateral patella facet, so those defects oftentimes can go ignored and patients still do well. But then which defects should be fixed? So if I have, especially a young patient, acute dislocation with an osteochondral fracture or delamination, that's someone I would consider repairing. And then if I have a chronic defect from maltracking that I can't simply unload with an osteotomy, I might do an osteotomy plus cartilage repair. So how do we deal with an osteochondral fracture or a chondral delamination in the setting of instability? I always like to repair it. These are young patients. I like to repair if I can repair. Sometimes you can. In this case, you remove the fragment. So as mentioned, which defects not to worry about? This most inframedial patella facet, there's a small little cartilage-only fragment in the gutter. Those defects, I worry about the instability. I take out the loose body. I don't worry about cartilage. And then if I have someone who has a very anterior on the lateral femoral condyle, so this counter coup, when the patella dislocates, that's not in the direct weight-bearing zone. Here you see that defect in essentially full extension. It doesn't articulate with the tibia. That's something I debride, maybe do a gentle abrasion, but nothing further. Repair what you can repair. The algorithm is similar to OCD decision. So if I have a large piece with intact cartilage, those I repair. And I've used screws, I've used little resorbable darts, I've used suture. And Pete Fabricant from HSS had looked into this small study, 15 patients, young patients, so average age 12 years. They repaired these cartilage-only defects and had very reasonable healing rates. So if I have a young patient, and with young, in this case, open growth plates, even if it's only cartilage, no bone on the fragment, I would try and repair that. If it's an older patient, 25, 30, cartilage only, I'm not sure that would heal. Those I would remove and maybe reconstruct depending on the location and size. So this is an example of a repair. Here you see the MRI. On X-ray, if you look closely, you see a little, almost looking like a sickle of a bony fragment. This is almost like an eggshell. This is from our friend Jack Farr, and he repaired this with sutures, a very cost-effective method. It's a resorbable 0 or number 1 PDS tied in the lateral gutter. It does require an incision. You could probably try to do this arthroscopically, maybe with resorbable darts. And this is his post-op MRI scan where it showed that this healed. You can see the mostly open growth plates. Reconstruction, well, reconstruct if you feel like you should do something but you can't repair it. So let's say that piece is cartilage only in an older patient, or it's fragmented into multiple pieces. This case is someone who has a weight-bearing lateral femoral condyle defect from a dislocation. This is someone who has a little bit more of a chronic recurrent instability pattern, but it's a large defect and it affects the median ridge, which for me is the signal that this might need cartilage work. So this is an example of a 12-year-old. She had 10 plus dislocations. Back to Sabrina's point, we shouldn't really allow anyone, especially not kids, to have 10 plus dislocations. I think too frequently our primary care physicians say, oh, this is fine, don't do operation, just wear a brace and do physical therapy. In her case, almost her entire lateral femoral condyle had cartilage defects from multiple dislocations that each pushed off small pieces. So she ended up with an autologous chondrocyte implantation, an MPFL reconstruction, and a hemiepiphysiodesis because she was in mild valgus. There's another example of a 20-year-old. He had 2 dislocations, had a pretty large piece that affected the median ridge. He's somewhat dysplastic, and he had an osteochondral allograft. You can see that well integrated together with an MPFL reconstruction. So the treatment options: debridement, osteochondral autograft for small defects, osteochondral allograft for larger defects. What's a newer version is morselized autograft cartilage, where you take a cartilage biopsy, you mince it on the back table, you mix it with BMAC and fibrin glue, you put that back in. That can be a very effective and cost-efficient method. And then autologous chondrocyte implantation, very expensive, but long history of good results. How do I choose? If the bone is intact, I use surface-based treatments. If it's compromised, I use an osteochondral procedure such as osteochondral autograft or allograft. So the small defects, inframedial patella, very anterior lateral femoral condyle, can be ignored. Large fragments should be repaired if you can. Reconstruct if it's a large defect and you can't repair. Thank you very much.